Thank you so much, Keri. The audience is still awake. You'll recognise there is an audience because we'd like to ask a few questions, or get a few questions asked. And if necessary, I'll pass on the questions if you don't hear what's being asked. And well, Kevin is chairing this, we'll limit it to a certain time, and then you'll probably hear some applause at the end of that.
Thank you, Keri. Can you hear me?
Hi.
Can you hear me, Keri?
Just about.
Okay. I was just going to say that I've got some disappointing news for you because we're way ahead, actually. We've got a gold card in New Zealand.
Wonderful.
And it entitles you to cheap fares on the bus and a free trip to Waiheke Island on the ferry. So we're well down the track.
Sorry, I missed that second bit.
It's a free trip to Waiheke Island on the ferry.
It's a gold card introduced by a politician that gives elderly people some free trips here and there.
Oh, wonderful, wonderful. That's really... one of the things about the gold card in hospital was they got open visiting and free car parking as well. So you've got to add these other things.
Thank you,
Wouldn't
Keri.
it be good if you could then also access your prescriptions and maybe get extra benefits and all that? The whole image of being VIPs and special and we're going to do more for you is really good, rather than people feeling they're on the scrap heap.
Well, we've got a political angle now.
Yeah, indeed. Winston will be pleased. Okay, audience, questions, please. We've got Steph here with the microphone. If you just put up your hand if you'd like to ask a question, and Steph will come over to you. Somebody's got to start. There we go. Perhaps if you just introduce yourself and brief, where you're from, and then Keri will know your background.
Okay, I'm Nikki Twigg. I'm working at Arahanui Hospice as a Palliative Care Coordinator, Team Leader. I just wondered, Keri, if you could just let us know, with this gold card that these patients have, do they get free access to their general practice teams and things like that with this gold card?
Sorry, Simon, could you just repeat that? I can hear you.
Nikki Twigg from a hospice setting. Does the gold card allow free access to general practitioner?
Oh, right. I mean, it's only been piloted in a few areas, but they are developing what they call locality registers, which are the same kind of thing. But the gold card idea should make sure that there's better communication across an area. So one area calls it coordinate my care. And yes, it should mean that when they go back to the GP, they're known as a gold patient, GSF, or part of the palliative care register. Different areas call them different things. We don't like to call them end-of-life care patients, by the way. It's a bit negative, so we don't call them that. But then there should be a whole lot of things that the GPs do. In the UK, I can't quite remember whether it's the same in New Zealand, but every patient has a right to a GP as of right. I know there's some countries where they don't. But every patient has a GP, but that doesn't necessarily mean to say they're seeing the same one or the continuity is as good as we would wish, but they have all, by rights, got access to a GP. So then the question would be, they go back to the GP, if they put on the register, we hope that the GP, the practice team will do an assessment, an advanced care planning discussion, and look at their physical needs and their emotional needs, and then discuss them and put the right kind of care in place. One of the nice bits, though, is that the receptionists know that this patient is a gold patient or a special patient, and they get prescriptions quicker. The practice nurse, the practice manager, all the other members of the team, it's very much a team thing. So there are other perks. Now, I'm telling you, we've got 8,500 GP practices in the UK and 35,000 GPs or something. So it will vary enormously, and some will do more than others. But certainly for some, it's a bit of a ticket to top-class care, which is what we're trying to look for, really.
I'm not sure, Nikki, were you asking whether it was free in terms of the cost? Yeah.
I wondered if there was funding associated with it.
Right. Yeah, I think Nikki's not realising that the GP system in the UK is different from here. We're a privatised system.
Yeah.
Some subsidisation.
So our system starts off from what we've got, which is free access to GPs as part of the NHS, and no money changes hands at all. But I mean, you have most other countries have a different system, but it's still can work because you have insurance and subsidised rates, don't you? So the money thing, I don't think should be an issue. It's just a slightly different structure. Is that right, Simon?
Yeah, different structure, but cost is a barrier to access to primary palliative care, and it's something that we're working on, and this could provide a useful tool to try and Trojan horse, if you like.
Yes, you mentioned the Trojan horse. So,
I do.
And is that because people aren't able to access a GP when they're most seriously ill then?
It can be, yes.
Yeah.
Okay,
Yes,
thanks,
and
Keri.
I know that we all have our different systems, and honestly, primary care in this country is changing. But the fact that everyone can have access to a GP, sometimes we forget that that's the basis of what we do. So.
Okay, other questions?
Hi, Keri. I'm Barry Keane. I work in community palliative care. My question was really around the relationship between general practice and specialist palliative care, because your presentation had a focus on coordination. You spoke about links with specialist palliative care, particularly hospice. I was just interested to know how Gold Standards Framework works in terms of coordinating care that encompasses community specialist palliative care or hospice.
So you're just asking about how Gold Standards Framework interacts with hospice and palliative care, and I just didn't catch that very last bit.
Yeah, that's largely the question, Keri, how it coordinates across the whole, inclusive of specialist palliative care.
Yeah. Well, I mean, I was working with specialist palliative care when we developed this, and we've always included teams as we've gone. And in fact, most specialist palliative care doctors and nurses find their work easier when practices are using GSF. So it's true that early on there was a little bit of suspicion. I mean, the whole relationship between GPs and specialist palliative care was a little bit frosty at some stages along the way, but we feel that over the years, over the decades now, it's eased off and people are much less territorial, and there's a sense that no one can do it all and we all need each other. There was a lovely article by Jeff Mitchell on a systematic review of the role of GPs in palliative care, and showing how patients really value the role of GPs as generalists. But then it works best when GPs can then consult with specialists on things that they're not so sure of. So it depends really how it's approached, hopefully not in a territorial way, but basically there's more need out there than all of us can cope with, and there's more complexity too. And GPs will do what they can do, and that's what we want to affirm. You know, what is the standard things that GPs and generalists can do. But when it comes to some specific things, when you get stumped, when you're just not sure about symptom control or whether you're doing just the right thing, then sort of consultation with specialists. And most specialist palliative care now want to be in that role of supporting GPs because, you know, so many people are dying and living and dying, such complexity. Specialists in this country anyway are mainly seeing very complex cases of people who would have died many years ago if they'd been alive, you know. So, but now much more complex conditions, and so they are very much needed for their expertise. But the basic things should be delivered by primary care. That was also John Ellishaw's vision with LCP, very much the same, if you've heard him speak, that on a busy hospital ward, the specialists couldn't look after every dying patient, so what they wanted to do was enable everyone to give a good general standard of care and then call in the specialists when they needed to. So we find that when they do GSF, there's more use of LCP and there's more appropriate referral to specialists. And many of the people who are leading this work now are the specialist palliative care.
Keri, if I could just add on there a little bit, I suspect it's something to do with our different GP setup in New Zealand, but we perhaps have issues where some GPs, if you like, are not prepared or willing to provide, 24-hour, after-hours cover, service, etc., and remuneration that goes along with it. You any comments with regard to that?
Well, we've got the same situation. A few years ago, myself as a GP, I remember when it was abolished, to our great relief, that we didn't have to do 24-hour care ourselves, and that's handed over to out-of-hours providers. So, in fact, that's some of the way that GSF started, because we started looking at the terrible traumas that were happening out of hours and then looked at, well, what can we do in hours to prevent the out of hours crisis? And really, that's what GSF is trying to do, get everything right so there are fewer untoward events out of hours. But so we have a situation where there's decreasing continuity as well in hours, but much more proactive planning can happen in hours, and then care is handed over out of hours, and that's one of the key things that we need to look at. That's one of the things that we focus on, the continuity out of hours. What kind of information are you giving to the patient and the family, the carers, faxing a handover form specifically to the out of hours provider, maybe doing a different algorithm for their care so that it doesn't lead to inevitable hospitalisation, that kind of thing. But, I mean, we've got a fragmented system too. I think maybe one of the things, you've got some patients who don't have GPs as well, and maybe the palliative care service takes over the care, does it a bit more sometimes?
Occasionally.
Yeah, which I think is where we were as well, although we're not funded to do that, so it doesn't work quite so much. So there's much less takeover and therefore much less territorialism, really, and much more sense that this is a tsunami waiting to hit us. That how are we going to be able to cope, all of us? And we're only going to be able to cope by all of us playing our part to maximal effect, and a good working relationship with generalists and specialists. So that's what I'm hearing all around the country when I do my talks, and today I was on the podium talking with hospice and specialists, and it should be that you work together really well.
Thanks, Keri. Other questions? What time?
Hi, I'm Joanne White from Rest Home Residential Care. One of the barriers that we find is that just a simple thing like having a resource kit, because we're not a hospital, we are not allowed to, and that would certainly make care much better if we could have access to a resource kit on site.
Sorry, Simon, could you just repeat that?
Yeah, Joanne comes from an aged residential care setting, and she's asking about resource kits. I think particularly around drugs. So it's not in vogue at the present time in New Zealand. How does that work in the UK?
What, drugs in the home, in the
home,
aged
yes.
care? Yeah. I suppose there are a couple of things about that. We try to, just a practical thing that we try and do with this colour coding that's one of the things that's gone down really well. The carers and the domestics and everyone contribute to the coding of their residents. So residents are coded sort of stable, years to live, unstable, green, amber, red for dying. And then when they get towards a certain stage, certainly, the green and the amber, that they have anticipatory drugs left, certainly before the dying stage, so that there's working with the GPs to make sure there are anticipatory drugs and PRN drugs left in the home for the patient. The other way of doing that is we have difficulty accessing morphine sometimes. You might have the same. Some people had to get what they call home office licenses to be able to keep some drugs on site. But we have a thing called just-in-case boxes. I don't know whether you've seen those. Have you seen those, Simon? Or just-in-case boxes. It's a nice phrase. It's just 4 main drugs. It was very much related to the cancer experience. So the 4 main drugs related to the 4 main symptoms in the final stage of life, the dying stage. So agitation, midazolam, secretion tyrosin or one of the glucopronium, pain, usually morphine, and I said agitation. I've just forgot. Nausea, and so haloperidol or one of the others. So those 4 main drugs are used, and they put in what they call a just-in-case box, and they're prescribed. They can be prescribed in primary care as well, and all around the country, people have put them together. But in care homes, in aged care facilities, that can also happen. So you can prescribe a just-in-case box for a patient. So it just means that basically in the middle of the night when someone comes in and you need the drug there, but you haven't got it, what do you do? Otherwise they might go into hospital, very costly. So it's a sort of anticipatory prescribing to leave the drugs in the home to enable someone to stay there.